Welcome to the Stoic Bodywork podcast, where we focus on balancing the body, opening the mind, and awakening the spirit. I'm Octavia, your co-host. Just a quick reminder, all the information shared here is for general informational purposes only and isn't intended as professional, medical, or legal advice. All right, let's get started.
Welcome to another episode of the Stoic Bodywork podcast. I'm Phil, the owner of Stoic Bodywork, and I'm going to technically have a co-host today, but we're just doing a bunch of questions. I came up with a giant list of questions. We're going to try to get through as many of them as possible. We'll see how many we get through. We might have to do multiple episodes here, but I'm not going to lie. Part of this is because nowadays companies have to produce content, and the content that I need to produce is about bodywork because not a lot of people know what bodywork is. I still get it in my practice just about weekly, if not daily. My apprentice gets it with what she does as well, learning bodywork and transferring from doing kind of a blend of massage and bodywork to just doing bodywork. So we're going to ask a bunch of questions. I'm going to go over them all and we're going to see how far we get. Let's get started with this. Let's get my co-host here. Octavia, can you ask me the first question on our list?
The first question in the provided list is, what is therapeutic bodywork and how is it different from a massage?
All right, let's start there. Therapeutic bodywork is different than a massage. We'll start with that part. Therapeutic is the key term there. Now, there's massage therapy, quote unquote, and a lot of people in state licensure get licensed massage therapist titles. Bodywork is the manual manipulation of soft tissue for therapeutic change. Massage is for relaxation. So right off the bat, the major difference is bodywork is always for therapeutic change. Massage is rooted in the Swedish techniques and is often based on spa practices, which is for relaxation purposes. So our major difference is in the desired outcome. Bodywork must always be working towards a therapeutic outcome. Massage can blend partial therapeutic outcomes, but is constantly working usually towards a relaxation outcome. Bodywork is, again, the manual manipulation of soft tissue for therapeutic change being defined as increase of blood innervation, hydration, or function of the tissue. So those are our major differences between bodywork and massage. Let's see about, now I might just end up asking myself all these questions myself, but we'll see. Octavia, can you ask me question number 2 from the PDF?
Certainly. Question 2 is, what does a first session with you actually look like from start to finish?
This is a good question. As far as what to expect when you walk in the door, you're going to come in not knowing what bodywork is, and you're going to leave knowing what bodywork is. You're going to come in and you're going to give me, we're going to do an intake form if it's your first time here. We are required, just like, beyond massage therapy, we are required with bodywork to do a pretty intensive intake, but we try to keep it as simple as possible. We go over medical conditions, medical history, what's going on subjectively, turning that into objectivity. If you come in and you say, hey, Phil, my shoulder hurts, I'm going to clarify that. I'm going to figure out like, hey, what's going on with that shoulder? Is it sharp, stabby, dull, achy, burny? Each one of those pain sensations has a specific direction towards what we should look at. If it's sharp and stabby, that's something happening to a nerve. If it's dull, achy, or burny, that's something happening with a bone. If it's sore or tender, that's a muscle. So the first session always has a little bit of like getting to know me, getting to know what bodywork is. And then we progress into what brought you in, what's going on with the body. And from there, it can go as far deep as I've had sessions where we see some of the intuitive side of what I do to see like, and then incorporating the fascial system to say, this injury that you're currently dealing with came from this thing that happened to you 20 years ago. I often have to ask people, like, when did you sprain that ankle? When did you fall on your tailbone? Have you ever had a disc issue here or had a dislocation or even a sprain here or there? We're constantly finding out new things as we're working on the body because the fascial system keeps the score, keeps the record. So when the whole session from start to finish can look like simply coming in and being like, hey, I have sciatic pain. Can you help me with sciatic pain? Oh, I feel different. Okay. So the first session is always a little bit of exploratory, but it's learning about what body work is and getting used to the work itself. Nothing super special to keep in mind there. Body work, at least the way I practice it, I guess some people might not practice it this way, but there's no draping, no getting undressed. So don't expect like it's going to be coming into a spa atmosphere. You're going to come in comfy clothing, and I'm going to work directly through that clothing. We might work directly on, skin if you're wearing shorts, obviously, work on the legs and the arms. Most people don't wear long sleeves, but you can. I work directly through clothing. So it's not a spa. Come in expecting to go a little deeper and look a little deeper, and then looking for, hey, here's what I found. Let's check back in X number of weeks. We typically don't go more than 6 weeks out because your body will start reverting. And then we make a plan. It's very clinical that way. Next question, please. Number 3.
Question 3 is, how do you assess a client before you ever put your hands on them?
This one happens every day, all day with my clientele. My first apprentice used to watch me do this, and she made comments on it. But I will listen to the way you walk in the room. I will watch the way you walk in the room. I will see how you're sitting during the intake form, or during, if I'm just checking in with you, if you're coming back for an appointment. I'm assessing as soon as I don't even have to see it, as soon as I can hear it, or just like random things. I'll watch your gait. How are the legs moving? Are the hips swaying? I'm checking the shoulder line to the hip line, to the ankle line, to the foot line, checking unilaterally from one shoulder to the next. Is one side raised higher than the other? Are they sitting in a non-comfortable position? Are they, what's their emotional state as far as how they're talking? Are they describing an injury and having an emotional response to it? Are they looking to, antsy or fidgety? How are you responding? That's your body moving. Body mechanics is also body speak. We're speaking with our bodies constantly. So I'm always assessing, what's going on even before I even, do any manual work. So even, having people point to things and just saying like, hey, it hurts here, or then assessing through verbal communication of, again, sharp, stabby, dull, achy, burny, which is it? Next question, number 4.
Question 4 is, what are you actually feeling for when you work on someone's tissue?
I am feeling for the fascia. Everything I do is fascially based. And so I'm feeling for what's going on at the fascial layers, from the retinacular, the very top layer, down to the epimysium, perimysium, endomysium, even into the visceral fascias or the deep fascial lines. Which fascial lines am I feeling? Which way are they moving? How is the tissue responding? Does it feel hydrated? Do I feel any striation or contusion or adhesion? Adhesion is the word that we use to describe knots. That's the clinical term. So I'm just testing all these things. Do I feel anything? Is there a warm sensation? Is there a cool sensation? What's the temperature? I'm feeling for all sorts of different things when I feel someone's tissue, specifically muscle tissue, fascial tissue, skin tissue, to feel like, okay, what's going on with this? And then using that fascial palpation to feel everywhere else. The number one thing that makes a great body worker, I personally believe, is being able to palpate fascial tissue and know what's going on there. Question number 5.
Question 5. How do you decide what order to address things in a session?
Ooh, that's okay. Well, how do I address in a session always is going to depend on what you brought me and what we need to do with it. And that's the subjective into objective. I take subjective understanding, what you're feeling, how you're feeling, the state in which you came in, the state in which you want to leave in, how did you sleep last night? All of the subjective pieces that you give me, that sharp, stabby, dull, achy, burny, it hurts here, Phil, it doesn't hurt there. I can do steps. I feel a little run down. I don't feel like I can activate correctly. And then I turn that into objective. Is that decide what order to address things? Yeah. So once I have the subjective, I'm turning that into an objective. And then I palpate and feel the fascia. And then I might jump around. So the order, once I palpate, can change instantaneously if I intuitively get a sense that, oh, I need to go over to this tissue over here, or this isn't working correctly, or hey, this ankle issue is actually due to the opposite hip. And this ankle is stabilizing for that hip because there's something going on there. And they've actually had this limp that they've just kind of gotten over time. And then the person goes, oh yeah, I had to wear a boot for 6 months because of, X. And I was like, oh, okay, that's why this ankle is compensating. So now I got to go back over to that other ankle and I got to fix that. Then I got to go up to that hip and then I got to go back down to the ankle. Somewhere in there, I'm probably going to find that they got some shoulder neck thing going on and they've been sleeping funny. And so there's no like set, like do this. I've written protocols as far as, okay, let's talk about frozen shoulder. There's a protocol that I've written for frozen shoulder addressing the rotator cuff, specifically the interstitial space of the subscapular space. Those are just guidelines, but I might have to bounce around a lot. So I address things in the order that they're given to me information wise, just like you do with any information aggregation. I guess that's a really good way to explain it is body work is a process of information aggregation with very little verbal input. We have to take in information from the body itself and the fascial system to then figure out, okay, here is my priority list of things to do and the order in which to do it. I'm quickly thinking that I'm just going to start asking myself these questions. Number 6.
Question 6. What does it mean when you say you're working the fascia versus working a muscle?
Okay, so I've been talking about this fascial thing here already. Let's talk about what fascia actually is a little bit. Fascia wraps all the muscles. So to keep this one a little bit simple, I talk about working with fascia because fascia wraps everything. If I'm just trying to work with muscle tissue, I have to go through fascia just to get to that. And fascia tissue wraps the muscle tissue, and fascia is what becomes the tendon ligament tissue of the muscle tissue, which then attaches to the bone and which has its own fascial interweaving connections, specifically when we're talking about how the Golgi tendon organs respond to the tendon, and the tendon is the muscle belly attachment and, the different layers of the muscle. So fascia wraps everything. And when I talk about working on a muscle, I'm usually honestly just using that to describe the area I'm working. If I'm like, yeah, I'm working on your bicep brachii, or I'm working on your coracobrachialis, or your pectoralis minor, or your pectoralis major, I'm just generally giving an understanding of like, hey, I'm working in this area and I'm targeting that muscle, but I'm working on the fascia. So when I'm saying working on fascia, I'm working on the tissue that connects everything. And when I say I'm working on a muscle, I'm pretty much just giving a base understanding of that muscle maybe is not doing its job correctly, or I'm working on this specific area, which happens to be this muscle. That's kind of where I'm going with all that. Question number 7, please.
Question 7. How long does it take to see real, lasting results from therapeutic bodywork?
Depends on the person. Everyone is a little bit different, their healing rates, but I say at least 3 days to see any change that might be permanent. And then there's a hard rule that I have that we don't go past 6 weeks. So we have this weird time frame where I work on you. 3 days later, your body has slept a couple of times. It has readjusted. The fascial system has come up with a new normal. Inflammation exchanges happen. Healing rates start. And then 6 weeks from that, if we don't reinforce that pattern, or if it doesn't get fixed in that time frame, it reverts over again. It goes kind of back to where we started. So I usually have some clients in a 3 to 4 week cycle where I'm like, hey, you need to be back within 3 to 4 weeks so we can keep working on this. It could be sooner, but I never usually work on someone within 3 days. I want 3 days of information. We need those 3 days of information to like, did you sleep okay? Because if you didn't, you're not healing. So what I did hasn't even healed yet. I've caused new inflammation. I've reminded the body, hey, you need to focus on this area. You need to do work here. You need to spend resources to heal this issue. This sensitivity doesn't exist anymore. You don't even have to worry about being hurt over here, person's body, because you're not, and you need to get over that injury. So we need at least 3 days for that. And then we want to see some subjective change. Headaches and migraines, perfect example. If we do craniosacral, working on headaches and migraines, and we look at, oh, okay, I've either had a intensity decrease or a frequency decrease. That's great result structures and gives us plenty of information to work for. If it's vasovascular headaches and we get a frequency decrease, then we know we've affected the craniosacral flow. We're getting better blood flow into the occipital muscles and the neck doesn't feel like it needs to squeeze as much. Awesome. So the frequencies come down. Maybe it's vasovascular and we only get an intensity decrease. All right, well, then we've done work to actually affect the area. This is going to be effective. We need to redo that work and also look for any other pieces that may be causing tension in the area. Maybe we need to go down into what's going at the pectoralis or into the rhomboids to see maybe if the shoulder blade scapular flexion or clavicular flexion and humerus flexion are causing any other tension lines. Maybe it's a hormonal thing with headaches, and we need to look at, okay, well, we've had a frequency or intensity change, but then it came back fairly regularly. Or maybe there was a hard rebound. They had a rebound headache. And then we know, okay, maybe there's some more hormonal stuff going on here. And we have to look at what those cycles might be and what's causing that. So it really does depend on the person to person, how quickly they're going to see results. But honestly, by the time someone gets off my table, they usually have a general sense of like, oh, that was helpful. And then, if they go and run a marathon after that, after I've just kind of worked on their ankle and it was because it was sprained and they're recovering from that, that was their decision to make. But, and the results are typically lasting because we are working therapeutically. We're working on blood innervation, hydration, or function of the tissue. So that's where the differentiation, massage therapy to body work, I'm always therapeutically focused. So the results typically are quite lasting. Let's move on to the next one. Number 8, please.
Question 8. Why do some people feel worse before they feel better after a session?
I want to clarify this. This does not happen to everyone. And the reason some people feel worse is typically due to an outlying condition, be it inflammation-based that they're either not aware of, they did not make me aware of, or they went and pushed it. Honestly, I'm not trying to be mean to people here, but I worked on something and they were like, yeah, I went right back to the gym, or they didn't listen. I can't diagnose or prescribe. I'm not a doctor. I'm not a medical professional. In body work, I will try to lead people towards, hey, I just worked on this. You might want to avoid doing actions that would aggravate that. And then I try to be a little bit more specific when I can. I can't diagnose or prescribe. I say, hey, you might want to talk to your trainer or talk to your physical therapist or talk to your, blah, 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 about not doing overhead presses because I just worked on your neck and you have some sort of compression issue going on in the cervical vertebrae. So any overhead movements is only going to exacerbate that. Or, trying to coach people through, hey, this is a simulation of a workout. Everything I just did to the body during a bodywork session is no different than working the muscles if you were foam rolling or doing a workout. So you might feel tired, or you might feel like you woke up the next day and you're like, oh, okay, I'm feeling that. Sore and tender, definitely. I've been working on different layers of the muscles, so you're definitely going to feel sore or tender. That's why you would feel worse before you feel better. Next question.
Question 9. What is the difference between what you do and physical therapy?
They're medical professionals and doctors, and I don't have the cool tools and the fun stuff they do. But I would say the biggest difference with this one's a tough one, and I'm going to get in trouble for saying this, but I'm going to say it anyway. Most physical therapists, non-DPT, so there's doctors of physical therapy. I work very close with a set of, not very close, but I work with a set of DPTs in the area that I'm in that they're wonderful. They do direct care. They're great at their jobs. They understand, there's this thing called the fascial system. They understand that it's not just about sending them off to their assistant and doing exercises and somehow that's going to fix things. A lot of physical therapy out there at the educational level does not teach the individual about the fascial system to the level, at least I know it, or even to a level that I think would be acceptable for what they do. I am doing more manual manipulation than I'm going to go out on a limb and say 80% of the physical therapists that are out there. I am working on the tissue, palpating, feeling for what's going on, running through, chain of custody of events in the human system, in the body, and what happened to the body and how it happened. Most physical therapists don't even have the time to do that. Specifically, anybody who's working with insurance. They got 5 minutes to look at you, maybe 10, and then you're off to do your exercises and come back while they're trying to manage 7 other different clients. The system's broken, the education system's broken. What's different between body work and physical therapy is the manual manipulation and soft tissue that they probably don't have time to it. Caveat here, DPTs, the really good ones out there, the ones doing direct care, looking at you, Instacare. they have tools that make actually them more effective than me in certain situations, right? They can get in there with the dry needling and stim. They can do the ultrasound to see what's going on at the tissue level. They can, doing the live imaging. They can do just general stim. They can do, they have other fancy things. And then they can also prescribe the actions that need to happen. Because look, if you're dealing with an injury, there's going to have to be some sort of balance and stabilization work that happens before strengthening. I'm taking care of not acute care, but typically desensitization, maybe a little bit of balance and stabilization. But strengthening, that's on the client, and that's where the physical therapy comes in. So it just needs to be done in the right order, and unfortunately, a lot of them aren't educated to do that. I just happen to have, nearly 18 years working on the human body and the education that helps me make that really effective. Question 10, please.
Question 10. What is the difference between what you do and chiropractic care?
This one's a little bit simpler. Chiropractic care works on the bones, and some chiropractors do get into manual manipulation, but it's not usually their forte, nor are they educated on it very well. Most orthopedics who become chiropractors are only, typically doing 1 or 2 manual manipulation techniques in school. All of these things are generally synergistic. The major difference between bodywork and chiropractic is always focused on the bones. And so they adjust, or they're working to get a bone into a specific alignment. I'm going to keep getting myself in trouble on this episode. Chiropractors who do no manual manipulation or refer to someone who will help with the manual manipulations of the soft tissue, specifically muscular, are not doing their clients any service, because the muscles are going to pull those bones back out of alignment. If the fascia system hasn't agreed to the change, then the bones will be pulled back out of alignment. You'll be right back in there. That's why you have the flying 7 chiropractors out there that just do crack, 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 crack. Come back and see me 3 times this week. I'll see you for the rest of your life. That is absolute bullshit. I don't like to curse in this podcast, but it's absolute bullshit. If a chiropractor is doing that to you, go find a doctor of orthopedic who's a chiropractor who has a plan for you to get better, not just adjust you constantly and expect things to get better. That's nonsense, and it's insanity, because it's doing the same thing over and over again without expecting different results. If you just keep cracking bones into position and do not fix the muscles that are acting on those bones, you're not doing the person any service. The fascial system will pull those bones out of alignment. So, major difference between bodywork and chiropractic care. Chiropractic care is always focused on the bones. Massage is doing the relaxation. Physical therapy is doing the recovery. Body workers, we're like the fascia of the wellness system. We're putting it all back together. Oh, cool. You go see your chiropractor? Awesome. Come see me. What's going on? Oh, what did the chiropractor say? Awesome. It looks like these muscles are affecting those bones. Let me get that figured out. Get the fascial system to agree to that change. Oh, you're recovering from this injury? Let's get the fascial system to work with that recovery process. Let's make sure it's protecting and not guarding, doing all the right things there. Oh, you want to relax? Well, let's make sure that you can, because if we don't fix the craniosacral flow and the occipital exchange issue with the front line, back line, and the scalp tension, the massage therapist isn't going to get you to relax because your body's worried about having another headache. So yeah, all these things do different things, but the body work, specifically on the fascial system, because the fascia wraps everything, we're working on everything. We're just not doing it at the level those individuals are doing it. So often we're a really good first step. Sorry, I got a little heated on that one. No offense to anybody out there, but there are some bad practitioners in all spaces. There's bad body workers out there too. Terrible body workers, just absolute quackery out there. People are charging ridiculous fees to do stuff that like, what did you actually do? Like, and I'm going to go off real quick, because if you're out there posting videos of your client, you got your hands wrapped around their gluteuses, and you think that a girl in a skimpy, set of clothing is entertaining and that helps the industry, you're fucking wrong. Okay? You're absolutely wrong. That doesn't help the industry at all. I've been fighting my entire career to get people to take me seriously, because I'm licensed as a massage therapist, but I actually practice as a body worker. And everybody thinks I just touch people inappropriate, and they make sexual innuendo jokes. And I'm effing tired of it, because this is a real industry and we really help people every day. I have over 900 clients in my bodywork practice alone that I've helped. I've seen over 2,500 clients in my career. We gotta get this nonsense out of the industry. All right. Girls in skimpy clothing, nonsense. Putting somebody in some weird hole where you're holding them inappropriate and saying it's a technique, nonsense. Okay. Get rid of this crap. Stop engaging with it. If you're listening to this podcast and you want to respect me in any way, Don't click on it in your scrolling feed. Don't look at it. Get rid of it. Downvote it. Make a comment. Get in the comments and be like, hey, this is stupid. Why are you posting this? You know, most people come to their bodywork sessions in the winter in sweatpants and a hoodie, and I work right through it. They're just in comfy clothing. Nobody shows up here in, you know, short shorts and bikini tops. It doesn't happen. It's nonsense. It's just on YouTube to make you click on it and watch it. Those practitioners, some of them out there are really good. There's a couple on YouTube that, yes, they've helped the industry, but they're also falling into the trap that we just keep playing into people's over-sexualization of everything. And as a society, we got to get over this, because it should be entertaining to watch someone do their job correctly and help people, not because it looks sexy. All right. That's rant over. Let's move on. Next question, please.
Question 11. Can therapeutic bodywork replace surgery in some cases?
I can't say yes or no. I'm not allowed. I'm legally not allowed to say yes or no in any way, shape, or form. And then I'm going to answer that question having said that. I'm not a medical professional. This is not medical advice. This is just my personal opinion as a practitioner who's been in the field for a really long time. Consult with your doctors. But here's the thing. Surgeries can help, but not all surgeries are required all the time. Specifically, when I'm talking about, what I'm really, really talking about here, not to get myself in trouble, is if the surgery is to engage with something that could be done fascially, then we should try the fascial route first. Frozen shoulder. Anything having to do with tennis elbow or golfer's elbow, which is actually medial or lateral tendinopathy of the elbow, which could be any one of the muscle groups, could be above or below. If supination or pronation of the wrist is the problem, then the elbow is going to compensate, and the shoulder is going to compensate. Carpal tunnel. If there's an aggravation to the flexors and extensors that are then swelling and pressing up against the carpal canal, doesn't mean you need to go in and trim the carpal canal. Maybe you should check for the flexor and extensor issue at the elbow or the attachment sites, or even in between the radius and ulna. That might then help the inflammation issue, so that inflammation issue calms down and the swelling stops. All sorts of different things like that could possibly be worked on ahead of time. And I think, honestly, a lot of surgeons and doctors would agree to this. They're all overwhelmed. The medical system is collapsing by the day. If they had people like me to refer to, but my industry will never become a medical profession. I'll say it 1,000 times. They'll never let body workers become licensed as body workers and not just massage therapists. And they will never consider us medical professionals. And honestly, I don't care at this point. I do the best I can in the industry that I'm in and help the people the way I can. Man, I'm going to get heated all through these questions. I guarantee it. But can therapeutic bodywork replace surgery in some cases? I can't say yes or no. I think it's a viable option, and I think more medical professionals would do well to understand what therapeutic bodywork is, and for the industry to train proper therapeutic bodyworkers to offload those cases that the medical professional feels would actually benefit from those, instead of going straight to surgery. And honestly, that is happening. Thank you, doctors out there and surgeons out there who are looking towards those options, because I've heard it a lot more recently in the last year or two than I ever did in my career. Next question.
Question 11. Can therapeutic bodywork...
We just did that one. Question 12, please.
Correction noted. Question 12 is, what conditions or presentations do you see the most success with?
What presentations or... Okay. Honestly, at this point, this is going to sound cocky, but at this point in my career, just about anything. I get some level of success with just about anything. And I'm at the point in my career where I say, give me 3 sessions to get some sort of change that we can work with. And if I can't do that, I'm referring you out anyway. And I think that should be a standard for practitioners to refer out when they know, hey, I can't help this, right? This is my conversation about chiropractors who are just cracking people for no reason. Massage therapists who are saying they're working on someone's, oh, you have you have these knots and these adhesions here. I'm going to work on those. Every time you're in, what are you actually doing to help this person? Like, why haven't you referred them out to a PT to be like, hey, I think this is maybe what might be going on. Who knows? So yeah, I think, there's a lot that could be done there, but all right, hold on. Are there people, what conditions or presentations do you see the most success with? Okay, I will say individuals who are coming in with a issue that has been overlooked by all the other professions, and that someone just needs someone to listen to what's going on and then try to put a plan together for them. That's what I do the best with. And people who are, dealing with a musculoskeletal issue in the fascial system, because that's specifically what I work on. Forgive the interruption of the episode, but I have a couple things I really want to tell you about. One is Stoic Sleep. I created Stoic Sleep to help get to sleep and to get better recovery out of my sleep. Sleep is one of the most important things we do when it comes to health and wellness. Number one performance drug, and also the only time we do oxidative stress repair, specifically at the DNA and RNA levels. So if you're not sleeping, you're not healing. And if you're not healing, you can't gain all of the awesome things you do from training. So I tested it for a year and I've now released it to the public. Thank you, Pure Bulk, as the manufacturer, for making that possible. Grab a jar at stoicbodywork.com/stoic sleep today. I don't think you're going to be disappointed. I take it every night and I love it. So get some great sleep. Grab a jar of Stoic Sleep.
Question 13. Are there people you won't work with or conditions you refer out?
Absolutely. One, I do not work with adolescents below the ages of 13 or 14. I like to work 16 and up if possible. I do that because I am not well versed with adolescents and their growth patterns. I do know that I can affect their growth plates, and fascia has a big thing to do with how kids develop. So I do not work with anyone below the ages of 13, 14, and I only make special cases from 13 to 15. If there's not another route, or if they're an athlete and they need help that way. Mostly with gymnasts, that's usually where I'm working there. As a side note, any underage individuals, 17 and below, that come in must be accompanied by a parent. That's a hard rule in my industry, but it's a hard rule it's not a hard rule that you can have parents in the building. Hard rule for me is parents in the room. We need to have discussions and talk, but we also need to support our young athletes and our young adults. There are many conditions that are considered contraindicated, which means I should not be working on, like pitted edema, or if someone's had an injection in a site within 36 to 72 hours. If it's a transmissible anything, if I can move it through the body, cancer, oncology, that's a whole separate certification someone needs to do any sort of bodywork or massage therapy with oncology patients. There are things that, we don't work on, and we are usually educated even in massage therapy programs, the contraindication stuff. You should be educated enough to know like when you should work and when you shouldn't work. I've referred out quite a few people to be like, hey, I don't work on this. I'll refer you out. If I know it's neurological, I might be referring out to the acupuncturist. If I know it's a bone that needs to get worked on, I might go to the chiropractor. If it's a PT issue, if they need to do some exercise or strengthening, or if I know like, hey, this is going to take me 10 sessions just to get into this tissue to be able to work on that. Why don't we try dry needling first and save you, a bunch of sessions? You can go that route. We absolutely, don't work on certain things and refer out. I wouldn't say constantly, but it's definitely something we do. Now question 14, please.
Question 14. How do you know when a client has reached their ceiling with bodywork alone?
If we're getting the same results, session to session, then I know like, hey, we've hit a hard limit on what we are able to accomplish. Now, what I usually do in that sense is if I get two repeating, like if they say like, oh, I was good for a day or two and then it went away. I was good for a day or two and then it came back. I might try working on something else, but I very rarely had an issue where I've been like, okay, bodywork is just not the answer. In any way, shape, or form. But we do want to look at the subjective and turn it into objective. I discussed earlier in the questions that if I keep working on the same area, then it's time to educate the client like, hey, I need to work over here. We need to try this. Or let's try a session of PT, or let's try. So it's case by case on that. But yes, clients can reach ceilings for bodywork alone. And that's honestly usually where we see like, okay, now it's time to look at a surgical intervention. When we've exhausted the bodywork possibility, which shouldn't be like 20 sessions. It should be like, hey, we've done this 5-6 sessions in. We're really not getting where we want to be. Let's look at some other options. Let's see here. Number 15.
Question 15. What does a full course of treatment look like for a complex case?
this is all dependent, but a complex case might require, it's going to require at least 3 sessions. I should have a general understanding of what we're getting into by the first or second session. And then by the third session, we should have seen some level of result. Either, if you're started at a 7 on a 1 to 10 scale, 0 being like going to the beach and 10 being like, take me to the hospital. If you started at a 7 and we got down to a 5, then we went back up to a 6 and we got down to a 4 and then went back up to a 5. Like, we need to see some little subjective understanding to turn into an objective. And then the full course of treatment. I've had clients where, we've been at this for 2 years, gradually getting better and better, but working through a bunch of things. That one thing, that lower back issue might still be the issue, but like their daily lives have improved greatly. The flare-ups are rarer. They have to come see me every 3 months instead of, every week or every 2 weeks. I have clients now that we started weekly and now they're down to they see me maybe once a year when something happens. Or clients who, if it was a complex issue, saw me for a little bit, went to another practitioner, they bounced around a little bit, but we always need to be working therapeutically. So the course of treatment could be, I guess the other question here is manual manipulation, cupping, myofascial stretching, different modalities might need to get put into place to help. But that includes going and seeking other options too, because those are just different modalities as well. So, all right, let's keep rolling with this. We're going into fascia and deep dive on fascia. There we go. Use English, Phil. This is question 1630. Let's get Octavia in here to help us out. Octavia, can you give me question number 16, please?
Question 16. What is fascia, and why does most of the industry still misunderstand it?
This could take some time. Sit down, kids. We got a story to tell. Fascia is the tissue that interweaves and intertwines and wraps everything in the body, head to toe, top to bottom, from the skin to the bone and back. It wraps all your organs, all your muscle tissue. Your ligaments and tendons are generally made of it. And the reason we don't know about it and it's misunderstood is because of the education on it. The research really didn't start ramping up till about 35 years ago. I was introduced to the work of Dr. G.M. Barteau of France, Jean-Claude G.M. Barteau of France, who wrote the book and did a web series on the living fascia. There's now a whole institute on the work he's done. That was the first images of live fascia tissue that we had. Before that, it was all cadaver work. And so, although we are learning more about it, most information in the research and data sets do not make it into the education system for at least 30 to 35 years. So it is just hitting the education system now. And honestly, there's so much other stuff that most medical professionals have to learn that it gets kind of, a couple hours here and there. I think don't quote me on the number, but I think most medical professionals are only getting maybe 5 to 10 hours of information on the fascia system in their entire education process. It's wholly inadequate. Every orthopedic should be really focused on it. Every chiropractic, should be focused on it. Even, in nursing, it can help to understand why it's hard to hit a vein when we're doing, if we're doing any blood draws or if we're doing any injections or we're trying to put a catheter. The whole cath lab team should, learn how to palpate fascia correctly, because you can isolate veins doing that. So it's misunderstood because there wasn't a lot of research on it, and the research that is now there is new enough that it really hasn't hit the mainstream education systems. It's barely even in the books because there's a process. Most medical education, I would hazard a guess, is somewhere 40, 50 years behind the research till it actually hits the education system. Should it be behind in some way? Yeah, you don't want the bleeding edge research being used in a medical textbook that fellows are using. But we need to speed up the process. We have the technology to do it. So that's why it is still misunderstood, because people don't learn about it and we don't have enough research on it. We're still even doing research to figure out what is it made of? How exactly? We got a lot of it understood, but there's a lot more to go. Question 17, please.
Question 17. Why did fascia get ignored for so long in Western medicine and anatomy education?
Your guess is as good as mine on that one, if I'm being honest. It's probably because we didn't understand what it was, because we were doing a lot of cadaver work as far as understanding what tissues were. And you're dealing with dead tissue. That's what cadaver is, right? So it's non-living tissue. Fascia is a very, very living tissue. This is the same thing we didn't understand a lot about bones until we started looking at live bone and not dead desiccated bone. A dead desiccated bone is like all gritty and it has the little pockets in it and stuff like that. A live bone is like pearlescent. It's beautiful. So yeah, we probably didn't know a lot about fascia specifically in the Western medicine system because we didn't look. We didn't know what to look for or how to look for it. And so we've only done that more recently. And we're getting there. We're adding it into anatomy for education. It starts at the fringes. It started with bodywork. I learned about it a little bit in massage. I learned about it before massage school, but there was some education in it when I was in massage school, and it's only gotten better there because I was trained by some really good people who were really smart and wrote their programs. Question 18.
Question 18. What does the research actually say about fascia that most practitioners don't know?
It literally, and I do mean literally, wraps everything. A lot of practitioners don't understand to the level at which fascia interacts with the entire body and all of the systems all at the same time. In my practice, I like to say that the body, the human system, is precognitive. The way it's precognitive is due to the fascial system. There's a lot of nerve endings in the fascia tissue. A majority of our nerve endings are in the fascia, and the body's using that information precognitively to do things, right? That information is getting to our brain, and then we're making commands out of it. But the fascia system is preparing for your next footfall. It's preparing for having to get out of the way of something. It's the next force or vector. It is dealing with gravity all day, every day. The fascia system is generally, again, precognitive. And the things that we don't know about it are the things that we need to know about it. So the research isn't enough. So when we're asking, like, what does the research actually show us and like tell us that most practitioners don't know? Freaking everything. We need to do more research on this to find out more. And a lot of people are starting to do that, but we have to find an ethical way first. That's part of the problem. Studying live tissue, you have to find an ethical way to do that. But most practitioners need to know that there is this thing called the fascial system. It is a part of everything, even down to how the body reacts to recovery from surgeries, how the body reacts to, post-injury issues in post-injury issues that have now carried through to create new injury, right? So a sprained ankle might come on because of fascial issues at the hip. That could come on because of fascial issues at the spinal line that has to do with the shoulder, that has to do with a wrist. Like, it's so interconnected that's what really people need to know is it's so interconnected. Next question.
Understood. I'll continue with the next question. Question 19. What is tensegrity and why does it matter for how the body holds and distributes tension?
Tensegrity is a term created by, or I'm not sure if it was created by, but it's definitely keyed by Buckminster Fuller. And tensegrity means I don't want to get too in depth on this one. Tensegrity is a constant measuring of forces to find the most equal balanced option. That's the simplest way I can put tensegrity is a set of force that is balancing other forces. And so it's using force to balance force to find a balance across everything. So you'll see the best way to see it visually is to go look up Buckminster Fuller sculptures, and you'll see like there'll be a log with some chains on it, and it's just floating in time and space. A lot of people have actually seen this. Some people have actually experienced it if they've ever done the 4-person leg over chair, where 4 people put their legs into a pattern and then create that. Or if anyone's ever done the popsicle stick frisbee things, where you fold popsicle sticks in a star pattern so then it all stays together, that's all tensegrity. A set of force and vector that finds a balance and equilibrium to hold something in place and or time. Next question.
Acknowledged. I'll move on to the next question in sequence. Question 20. How does fascia communicate with the nervous system?
Fascia. How does fascia communicate with the nervous system? Fascia holds most of the nervous system in place and wraps it and protects it. So most of the fascia is innervated. It has the actual nerve in it. So it's not only helping the nerve ending pick up the information and send the information, but it's right there at the site at what the information is actually being addressed at. And then it's also part of the hydration function of the tissue and all that stuff. So that one might be beyond my scope of practice, to be completely honest, but the fascia has a lot to do with how the nerve can take in information and is actually acting on the nerve tissue itself. So it's kind of a bilateral communication function and not just a unilateral, like a corpuscle would be. Like a Miser corpuscle is, what level of cold or hot are we feeling? The fascia is kind of a bilateral of being able to, like, I have Miser corpuscles and they tell me of something, what temperature something is, cold or hot. Wait, is that Miser or is that the pressure ones? I always get the names wrong. I apologize. Let's use the pressure ones. Fingernails, super important. Fingernails are there so that you can feel things, because what you're feeling is not just the pressure at the skin of the fingertip. It's the pressure being pressed back against from the fingernail itself. We do that at bone level, but fingernails give us that little extra. And then we also have these corpuscles that feel temperature. And they're like, oh, this is hot or this is cold. Well, I can't just like mentally be like, feel cold, feel hot. I can kind of simulate it, and I can't really just be like, feel pressure, don't feel pressure. The fascia is able to not only feel with the nervous system, but can also affect the nervous system by simulating those things. If I say like squeeze, but I'm not actually squeezing, that's a poor example, honestly, now that I think back on it, but I'm going to go with it. That's what the fascia system is kind of doing to the nervous system. It's like a bilateral communication. Next question, 21.
Question 21 reads, what is the difference between superficial fascia, deep fascia, and visceral fascia?
All right, let's get into the layers of fascia. Those are the ones that most people get educated on in even Western medical systems, as just that. It's that detail. Superficial fascia, deep fascia, visceral fascia. Superficial fascia is retinacular and the mycelium, which are the three levels of the muscle. There's another layer in there, the interstitial space. That's what we consider superficial fascia. Deep fascia is underneath of that layer. It can include the endomycelium, but also the interstitial spaces between, like, let's say your rib cage and everything. Like, think deep, like deeper is deep fascia. And then visceral fascia is fascia around the organs themselves, so around the viscera. So viscerofascial areas are around the organs themselves and the tissue that makes up the organ. The deep fascia is the surrounding areas from that, including the interstitial spaces between the fascia of the organs themselves, and then above that is the muscular level and then the retinacular level. So there's some argument as far as which level starts where and is where. I go with the 13 levels, the 13 different classifications that are broken down into the three major zones. I would consider these zones, right? So superficial fascia, deep fascia, and visceral fascia, those are like zones of fascia. In that superficial fascia, like I said, we have the retinacular, which is that skin upper level, like how the skin moves across things, and everything's connected. But then we have epimysium, perimysium, and endomysium, which are the three levels of the muscle itself. The upper level, the belly, the inside level, the belly of the muscle, and then the attachment to the bone, the mysium that actually attaches the bone. There's some tendon and ligament, other stuff with attachment site and stuff like that. So yeah, these are just classifications. We need a better mapping system, and we need a more agreed upon system. Somebody needs to like ISO this, like come up with an ISO standard. Like we call it this. Although in the medical system, we constantly rename stuff. Like the perineal is now fibialis. Like we got, and the naming system is kind of crazy because we named things so long ago, like the nodes of Ranvier. It's one of my favorite ones. Nodes of Ranvier are the fat deposits around the nerve tissue to create saltatory conduction. Those are called the nodes of Ranvier because Ranvier named them. Things are kind of crazy. We need to come up with a better naming system because this stuff's too complicated at this point. We keep learning more. We keep adding to the system. Vernacular is hard. All right, let's go on to the next question. See if I can wake Octavia up. She can tell me what I don't know. Octavia, can you give me question 22? Just the question, please.
Question 22 is, can fascia actually be released, or is that terminology misleading?
That's a pretty solid question, actually. I should have read some of these ahead of time. I was trying to do it like off the cuff. Can fascia actually be released, or is that terminology misleading? That terminology is misleading in the sense that you're not releasing fascia. What you're releasing is fascial adhesion and fascial banding and fascial calcification. I would rather the term, if I could coin one, please let me coin one. I've been doing this nearly 20 years. Can I coin a term, please? We're doing fascial reprogramming. And actually, I coined that term because that's actually what I do when I reprogram athletes. I call it fascial reprogramming. We are changing the programming of the fascia. We're not really releasing anything. Because the fascia is constantly under tension. That is its job. It's always using that tensegrity thing to find force and vector and to balance things out. So I would say that no, we don't really release things. We reprogram them in the fascia. It's more like a program. So that was a really good question. I like that one. But again, am I allowed to coin that phrase? Please let me coin that phrase. All right, next question. Please read out number 23.
Question 23. What does dehydrated or restricted fascia actually feel like under your hands?
Dehydrated fascia will feel very sticky. No. Yeah, a little. Well, depends on the level of dehydration. I know you say it depends on things a lot, but dehydrated fascia is a bit sticky. It can be a little bit banded, hard to address. It's not very happy. It's kind of angry. Now, if it's calcified, if there's some calcification going on, that's a little bit different. That's going to have a little bit more, I don't want to say gritty, but maybe that's a term I could try to use. That calcification feels more like trying to move cardboard compared to plastic. And dehydration feels like trying to move sections of heated plastic in like a normal plastic layer. And then damaged fascia feels more like a pattern that doesn't make any sense. It's just kind of going all over different places. What was the other part of the question? Restricted fascia? Restricted fascia feels restricted. Actually, it's kind of like, you have to test it in all. Okay, that's a good way to explain this. Fascia is 3-dimensional. Humans are 3-dimensional. We often think in unique like layeral patterns, like 2-dimensional, like this layer, that layer, this. Fascia interweaves all the layers, so you really have to think. It's a total mind F. You have to think 3-dimensional. One, you should do that working with the human system anyway. But you really have to think 3-dimensional of like this fascia, and you also have to know how fascia organizes itself. It's not a uniform pattern. The fibers might become uniform and have uniform glide and slide, but the pattern might not be uniform. So you're kind of feeling for like, okay, what's the pattern feel like here? What is it attached to? What is it pulling on? Is it moving, sliding, and gliding on its own? Or is it pulling on something way over there? Is it being pulled by something? Is it acting on a bone? Is it acting on a joint? Is it acting on another muscle set? Is it stuck to something? So dehydrated, again, feels, they all feel a different way. And this is why palpation is the number one skill. It's hard to explain. You have to actually feel it because the explanation might not necessarily be like how someone else thinks through that palpation set. Next question.
Question 24. How does trauma, physical or emotional, get stored in fascia?
Not a doctor, cannot diagnose or prescribe, not a mental health provider or practitioner. Fascia stores everything from emotion to physical injury. The fascia system is trying to protect you all day long. It's trying to figure out force and vector. It's trying to prepare for you doing something stupid you're not supposed to do because your lower back has an issue. It is protecting you, always protecting you. And as your greatest protector, it knows when you have problems. And it knows when you have emotional problems too. It knows what emotional abuse looks like. It knows what physical abuse looks like. I know that because I went through all of those. I'm not saying that makes me special in any way. But I know what the patterns of my physical abuse against me are. I know what the patterns of the sexual abuse against me were. I know how they represented themselves in the body. I also know what the patterns of breaking my femur. I know what that looks like. And the pins that I still have in the top of the greater contracture of my femur that mess my fascia up constantly. And I've seen it in thousands of clients. I've worked with over 2,500 different clients, 900 in my current practice alone. I see the patterns, and the fascia is trying to protect you from or help you with those patterns. The body doesn't want to be in pain. I don't know if a lot of people know this, and I think it can really help people's mental health when you understand that your body is its own health structure and its own thing. You are a mental construct that controls that health body, and there's a spiritual health body on top of that one. And in Stoic Bodywork, it's based on balance the body, open the mind, awaken the spirit. And that all has to do with the fact that there's 3 health bodies. The physical health body is interwoven by the fascial system, but the emotional system, the mental health body, can apply restrictions to that fascial system very readily. And the physical body is trying to help the mental body out by predicting experience and helping with experience. And so if the mental health body is expecting a traumatic injury or expecting to relive trauma or be through another traumatic response, the fascial system is going to prepare for that. It's going to tighten up. It's going to protect for, if it's physical abuse, it's going to protect against that. And I don't mean it has to be, those types of traumas. But it could just be like a car accident and your body's like, oh, they broke their ankle in this car accident. And so they're, your fascia system is going to help protect you from that, but also prepare for it to happen again. And the fascial system is smarter than we are on the physical level because it will prepare for an injury that we don't even know is possible or coming. And then when we keep this is like the overstress stuff, like people keep doing like baseball players to keep pitching. The body's like, oh, this shoulder is not doing well. And so then they start pitching poorly and they're like, and so they keep pushing through it. And then all of a sudden their wrist starts to hurt and they think it's a wrist issue. Well, the body let that wrist issue happen because it was like, dude, you're going to break or dislocate this shoulder. So it has all these forward warning protocols that it puts in place. We just ignore them constantly. That's why I say if you want to get better mental health wise, realize your body doesn't want to be in pain. It's trying to tell you hey, I don't want to do that. And you're responsible for it. You have to take care of it. So a little far afield on that one. Sorry. But yeah, it's stored in the fascia. It shows up in movement patterns. It shows up in restrictions, in early warning signs of one injury occurring that was actually due to protecting the body. Like if the body thinks that the shoulder is going to get dislocated, but it can let the forearm break before that happens, it's probably going to. It's going to try to protect what it feels is going to be the most catastrophic failure by allowing something else to fail first, like a crumple zone in a car. Sorry about the interruption, but I want to tell you about the course that I released recently. If you're interested in self-awareness or have heard anything ever about manifestation, I highly recommend checking out manifestationstatecraft.com. It's the in-between between hustlecraft and that wishful thinking that doesn't really work. You can hustle all day long and get nowhere, and you can wish, and also get nowhere. But if you learn the skills that I talk about in the course, you can find the middle ground there and turn your hustle and effort into results and turn that wishful thinking and imagination into the creation of your dreams. So make your imagination become reality at manifestationstatecraft.com. You can use code STOIC to get $50 off the full course, or just check out the free preview and see if you like it. I hope you check it out, manifestationstatecraft.com. Next question.
Question 25. What is the role of fascia in chronic pain syndromes?
What is the role of fascia in chronic pain syndromes? Inflammation control, restriction of movement, function, and pain sensation in some way or another. Support structure for injury. If a joint or a bone or the nervous system or the central nervous system is in danger, it's trying to support that. Supporting tissue damage that is in the area by either tourniqueting it internally or by providing some sort of support. So another muscle group. Common one for this I see is any of the syndromes that involve like a tendon or ligament. Like if we talk about IT band syndrome. IT band syndrome is the end result of the IT band trying to help the quadriceps or hamstrings fascially. The IT band is in a groove, a fascial groove. It sits in this fun little fascial groove, And if it comes out of that groove, the reason for that is because the muscular structure, either the quadricep or hamstring tissue, was like, hey, I really need an anchor point, or I really need help doing this function, or maybe the femoral head is in rotation, or the tibia, fibula, and femur are in rotation at the knee line, or the ankle's not stabilizing correctly. And so some sort of rotational pattern has occurred. And the tissue, because it's all lazy, muscles are lazy, has attached itself fascially, has created some sort of like, hey, IT band, I'm the quadricep. Hey, IT band, I need some help. Can you help me out? And then it like kind of locks onto the IT band, and then it ends up pulling that IT band out of the groove. And so we constantly get an inflammation result. Most syndromes come from an inflammation issue. Inflammation issue is trying to heal tissue, and it's trying to heal tissue because the fascia system has decided at that point, like, hey, there's a massive issue here, and I keep having to do this action to help protect from that. Next question.
Question 26. How does fascia affect range of motion? And why does stretching alone often not fix it?
Fascia is the answer of range of motion. Now, range of motion has two different specific things: flexibility, the range of motion of the muscle, and mobility, the range of motion of the joint. Now, fascia interweaves everything. So fascia restricts to protect either the flexibility or the mobility. Again, mobility, range of motion of the joint; flexibility, range of motion of the muscle group. Let me go over this question one more time, just to make sure I'm getting it correct. Affect range of motion. Yep. And why stretching alone does not help. Well, to stretch fascia, you have to engage it. And to engage fascia, you either have to apply heat for relaxation purposes, but that doesn't engage all levels of fascia, just the superficial versions, or a stretch that is more than, on average, 90 seconds. Some people it activates at 60 seconds. Some people it activates at 110 seconds. Let's go with a round number. Average around 90 seconds for the stretch to actually affect the fascia. The fascia is restricting the stretch immediately. And actually, the fascia is in restriction constantly. For an action to occur, let's say the eccentric action of, I keep going off on these questions. There's no such thing as a push. Pushes don't exist in the universe. Everything is a pull. Push is a described action. We have eccentric and eccentric, which is just antagonist and protagonist, and also stabilization and contraction in the fascial system. So if we stop thinking about the muscle groups and start thinking about training fascially, we have eccentric and eccentric. Eccentric action is when the insertion point is moved towards the origin point. That's contraction, eccentric contraction. Eccentric is the point at which the lengthening of the muscle, quote unquote, happens, which is when the insertion point moves away from the origin point. Under those two different circumstances, there is load to the system, and the fascial system is trying to figure out what to do with those physical forces. And so it does something called stabilization or contraction. If the tricep is in length into an eccentric and the bicep is in an eccentric, contraction and lengthening, the lengthening of the bicep happens due to the contraction of the tricep, which is moving a joint. And that joint's mobility, you didn't think I'd come around to this question, did you? Is controlled by the fascial structures that wrap that joint and those muscles. Just like the length of the muscles is the innervation and weaving of the fascia inside the muscle fibers themselves. The Golgi tendon organ is what tells the muscle tendon attachments what the proprioception capacity is, the actual strength coefficient factors of the muscle and tendon ligament attachment. But the fascia is doing the support for the action. So when the eccentric action, the contraction of a muscle happens, whatever fascial line that is contracting in, the opposite and supporting, so the primary and secondary supporters of that fascial line become the stabilization for the action. This is why unilateral things can actually happen. This is what allows us to move in three-dimensional space without just falling over. The fascia itself is constantly figuring out what force and vectors to use through stabilization or contraction. In order for the superficial front line to contract, the superficial back line must be doing stabilization. In order for the superficial back line to be doing contraction, the superficial front line must be in stabilization. So there's always an equal and opposite. It's always another pull. There's one pull that's creating another pull. That's tensegrity. One pull is stabilizing. The other pull is actually moving through action, doing contraction. Eccentric, eccentric. Start training fascially. You'll do better and everything. This was the Shaolin monks and the Shaolin Kung Fu that I did. It's all fascially based, all through calisthenics. All calisthenics are fascially innervated movement. This is why calisthenic athletes move the way they do instead of just being a specific muscular structural athlete like a power lifter or a bodybuilder. A calisthenic can use that contraction. Now, you don't have to train that. You can use fascial training to make anything better, but that's why we see the differentiations. That was a long one. Let's move on. Next question.
Question 27. What is the relationship between fascia and inflammation?
Is there a direct correlation between fascia and inflammation? Yes. There's a lot of inflammation in the fascial layers. That's, there's a whole, I really wish I remember actually, you know what? This one I'm actually going to ask. To answer this question, Octavia, can you tell me what the disease is called where there's inflammation in between the fascial layers, the interstitial spaces?
The condition you're referring to is called fasciitis. In particular, if there's inflammation in the fascia itself or in the interstitial spaces, it can be described as fascial inflammation. An example is plantar fasciitis, where the fascia on the bottom of the foot becomes...
But there's a specific one that attacks those interstitial spaces. Is it multiple sclerosis? Am I getting that correct?
No, the condition you're thinking of isn't multiple sclerosis. The term you likely want is eosinophilic fasciitis, also known as Shulman syndrome.
Shulman syndrome. That is the one I was thinking. Yes, that one is very rare. So sorry, that little side tangent there. But that little side tangent gave us, honestly, the easier answer here. Itis. Fasciitis, right? If there's inflammation in the fascia. Now, if there's inflammation in the fascial system is going to respond to that. And it's going to try to get rid of it however it can or protect itself from creating new inflammation issues. So the relationship between fascia and inflammation is, my personal opinion, the precursor to about 70% of all diseases. When our body is unable to deal with the levels of inflammation that is being created in the fascia and other spaces, that's when more disease can set in and our body becomes overwhelmed. And it's a reoccurring pattern of disease because the inflammation starts actually doing damage to the tissue in the area. Can't really go into more of that because it's outside the scope of this question, but big thing, inflammation, control it. Next question.
Question 28. How does fascia respond to load and training, and why does that matter for athletes?
Fascia is constantly trying to figure out what you're doing to it and why you're doing to it. What you're doing to it and why you're doing that to it. I find that we are dineural creatures and we follow lunar cycles. And our sleep cycles are one of the most important things because our body needs to heal, and in order to heal, it needs to sleep because the only time we do DNA and RNA repairs during our sleep functions, which is oxidative stress repair, protein synthesis and repair of muscle tissue, but also repair of fascia and hydration of fascia. You do not rehydrate your metabolic hydration till later in the evening, which is when we replenish our metabolic hydration, which is part of the fascial system. And also our mitochondria go to work for repair function. So when we're talking about how the fascia responds to load and training, it's looking at a pattern. It wants to know what you're trying to do with it because it's precognitive. And so if you do something one way and then do it a different way, it wants to learn what the difference between those different methodologies are. If you do one thing one way and it went really well and it's successful and your body could be as lazy as possible to do that thing, it wants to repeat that. The body's trying to conserve energy. It doesn't want to use energy. The fact that we try to do things at crazy ability levels, we have to train the body into that because it's trying to conserve the resources it has. And so if you don't give it enough resources, the fascial system knows about that. It's all interwoven. But when we talk about load and just straight training, physical training, fascia is looking for, how did you do something? Why did you do it? How many times did you do it? And are you going to make me do it again? It's trying to calculate all of that so that it can tell the system to create structures to either make that make yourself stronger in that area or make you more capable of doing that for repeated times. This is the difference between an endurance athlete and an explosive power athlete. This is also the difference between tendinal and ligament strength, which people don't think you can train, but you can. There's a whole Shaolin method of work called squeeze, twist, and stretch. That's why my forearms are the way it is. That's why my hands don't get tired during constant, hour after hour of bodywork sessions working on people. Ligament and tendon attachment and strength come from fascial interaction. This is the key to isometrics, to use isometrics in action. People think an isometric is a stagnant hold. There's no such thing as being stagnant. The fascia is constantly trying to find force and vector and find the most efficient way to do something. There's no such, isometrics don't exist the way people think like an isometric exists. An isometric isn't just like squeeze and hold. It's a constant calculation of like, how do I squeeze? How do I hold? Because a muscle needs to relax and recontract. If a muscle is fully in contraction and burns up all its ATP, it has to relax to even just to get new ATP into the function, even if there's no creatine in the system to do ATP. Sorry, that's getting too far afield. The isometric can happen during contraction and lengthening. The isometric is the restriction of mobility or flexibility. That's all an isometric truly is. An isometric, the truest form of isometric training is using the fascia and the muscles to restrict mobility and flexibility. Doesn't mean you still can't go through the action. This is why slow and controlled and time under tension works. That answers the question right there. I don't feel like explaining it further because I'm just going to get into hard calculations of strength coefficients and it's just going to be nonsensical. It's going to be too much for the course of this. I really want to, but another time. Next question.
Question 29. What is the myofascial meridian concept and how much do you rely on it in practice?
I don't rely on it at all really because I think it's a modality function that people have created. Well, okay, that's not true. I have to be careful what I say here because myofascial meridian concept is someone's concept and they created it and they sell it as that. The myofascial meridian concept is a really good concept. I wouldn't say it's a principle of action when it comes to the fascia. I think we have fascial lines. Thomas Meyer's work with mapping all that out is great. We need to go deeper and stop sectioning off fascia research into like, I created this new shiny understanding and idea and I want to sell it to you. We need a more cumulative idea. So I'm not going to get too much into this and I'm not trying to say anyone's wrong. I think the myofascial meridian concept is trademarked and I don't want to talk about it. That's I'm going to say it that way. Let's see. Next question from Octavia. Oh, that's not what I wanted to do. There we go. Next question, please.
Question 30. Where do you think fascia research is headed in the next 10 years?
Cool. Yeah. What I just said was kind of a lead up into this. In the next 10 years, I think we are going to be able to use AI to figure out how the human system actually functions. And I think the driving factor will be finding, this is like some like prediction stuff. If any of this comes true, I want a gold medal. Or no, I want a doctorate. Somebody give me an honorary doctorate at this point. Seriously. I don't care who, but put me on stage, give me the little piece of paper, let me give a speech. Maybe I'll light it on fire in front of everybody. We'll find out. 10 years is a long time for fascial research, especially in the age of AI. I think in 10 years, we will understand how to give the fascia the nutrients it needs to repair most small tissue issues, as well as understand how fascia and training actually work, how to actually train fascia and not just the muscles, that the muscles are the drivers of the fascial responses and the fascia is really in control of the show, and that we should be training the fascia, which is also the mind-body connection and the gut biome axiom connection, but to how to provide nutrients to the system to see performance gains and healing rates that we didn't know the human system was actually capable of. I think you will find that when people realize the food system is broken, the Western medicine system is broken, and it's not everyone's fault. It's just that the education is bad. We don't know enough. And the systems that have put in place by the people that are the powers that be didn't give a shit about anybody. and just wanted to make money, and the human system is capable of things that we have no idea that's actually capable of, I think that's where we'll be in 10 years. I think we will look back and be like, we didn't know anything. Holy crap. We had 5% of the information. Now we have 50% of the information. And that 10x change will be mind blowing and baffling. I could also be completely wrong, and we continue down the track that we are currently on and get nowhere. We've done that for the last 50 years. We knew about fascia 50 years ago. 35 years ago, we got Dr. Giambarto's work, and most orthopedics don't even know about the different layers of the fascia today. That's where we could go. I'm hoping that doesn't happen. In the age of AI in 10 years, we will have found a new way of doing things, and the fascia research will show us how to be happy, healthy humans and be extraordinary at just even our daily lives, but also a level of athletics that we didn't know was even possible, even though we have some extremely high performing athletes today. So I'm a little hopeful on it, but it really kind of depends on what they do and how they do it, and doing it morally and ethically. So yeah, we'll see, but it could be astonishingly amazing. Those are two crazy words to put into one sentence. So let's see. Thank you for listening to this episode of Stoic Bodywork podcast. Those were the first 30 questions on my 100 question list. So that was covering what I do and how I work, and also a deep dive on the fascia. We're going to get into anatomy, physiology, and pain science. We're going to get into functional training and the Stoic Bodywork methods. We're going to get into the industry and my major critiques and differentiators between all the stuff. More angry parts, I'm sure, of me going on rants. Client education, self-care we're going to cover, and we're also going to cover the Stoic brand and philosophy and the story behind it. All of that to come on future episodes. This was a great start to get into those questions. Check out stoicbodywork.com if you're in the area and you need some body work. Check out stoicbodywork.substack.com where we host the podcast. Get subscribed. Big ventures that I've been getting into recently, you can go to stoicbodywork.com/stoicsleep and use code STOIC to get $5 off your first order. I've been taking Stoic Sleep every day pretty much for the last year. I took a year to research and develop the product. Pure Bulk, who is we're an affiliate of Pure Bulk, manufactures Stoic Sleep, so I know it's high quality. I know it's tested. You can go to purebulk.com and use code Stoic Bodywork to get 15% off your first order, or 10% off any order after that. Stoic Bodywork 15 to get 15% off. Stoic Bodywork to get 10% off any order after that. You can go to manifestationstatecraft.com, the course that I published to help with self-awareness and turning your imagination into reality, and use code STOIC to get $50 off the whole course. And check out more of this podcast as we dive through more of the questions. Thanks for listening. Catch you on the next one. Hi, sorry about the interruption for the episode. I'll make it quick. I have some cool things I want to tell you about. First, Stoic Sleep, the sleep supplement I take every night. I took a whole year of my life to design and test it out before releasing to the public, and purebulk.com has agreed to manufacture and supply it for me. So if you're looking for better sleep or just want to get better quality sleep, I highly recommend it. Again, I take it every night, and I have had some awesome results for myself and my clientele. I also have manifestationstatecraft.com, which is where I talk about self-awareness and how I found the middle road between that hustle craft, grind, and then burn out, or that wishful thinking, oh, it would be so nice, but I never, ever got there. Manifestationstatecraft.com. Use code STOIC to get $50 off the whole course and find out how you can turn your imagination into your reality today.